Welcome, everyone, and thank you for joining us. Today's webinar focuses on cryoneurolysis as a minimally invasive option for managing spasticity, with an emphasis on practical clinical decision-making for PM&R physicians. We're pleased to welcome Dr. Arun Kalava. Dr. Kalava is double board certified in anesthesiology and pain therapy, completed fellowship training at Mayo Clinic, and serves as chairman of the American Society for Post-Surgical Pain. He's the founder of TampaPainMD, Ultrasound Experts, and an internationally recognized educator in ultrasound-guided pain interventions. Please welcome me and join in Dr. Arun Kalava.
I just wanted to go over our mission for the American Society for Post-Surgical Pain. It was established 2 years ago, basically to provide a platform that encourages dialogue in managing post-surgical pain for surgeons, anesthesiologists, pain physicians, emergency physicians, physiatrists, and other ancillary staff. Please visit our website to learn more at postsurgicalpain.org. We have to pay homage to the inventors of cryoneurolysis for spasticity. This is Paul Winston and Dan Vincent from British Columbia, Vancouver. Paul, as you know, is a physiatrist and reached out to Dr. Vincent, who's an anesthesiologist, to figure out how they can introduce cryoneurolysis in treating spasticity. These are the conflicts of interest I have to declare. Before we dive into the presentation today, I wanted to bring your attention to this workshop that we have. We have three workshops this year, one in San Diego in February, one in June and October in Tampa, Florida. So if you like, you could scan the QR code here to learn more about it. The objectives for today's presentation are to talk about the basics of ultrasound, introduction to cryoneurolysis, review the mechanism of action, neuroanatomy and safety profile. We also will be talking about different targets for treatment of spasticity. We always talk about the art of sonography, but I would like to put emphasis on the pressure part because that seems to be missed. So this is how you place your probe. You align, you put pressure, you rotate, tilt as needed to get a better image that you're looking at. What probe to use? Well, it depends on the exam you're doing and also the depth of the particular anatomical structure you're looking at. Most of the time with muscles, we probably are looking much deeper, but a lot of times, 90% of the time, I would say I would use a high frequency probe. As you know, frequency is inversely proportionate to wavelength. So if you have a shallow nerve block or a procedure, you would use a high frequency. The frequencies are usually mentioned on the probes, as you can see. I would use a low frequency probe if I'm doing a hamstring procedure, because I want, get a wider angle and a deeper penetration of the image. When it comes to the setting, there's different ultrasounds, as you know, in the market. Try to be on a neuro mode or an MSK mode so you get a good image and the best optimal image possible for that examination. Gain is just brightness on the screen to your visual liking. Depth is always measured on the right side of the screen. Here's 1, 2, 3 centimeters. When we're doing this presentation today, we'll be using certain terminology like anechoic, which is there is no echo coming back from the ultrasound beam that was penetrating these tissues. Usually you see anechoic structures in the body, which are bone, blood, air, and lung. Hypoechoic, a lot of times muscles are hypoechoic, nerves can be hypoechoic. Hypoechoic structures are white on the screen, and those are usually periosteum, pleura, and nerves can be hyperechoic as well. When you look at these ultrasound images, there is two ways of approaching cryoneurolysis. You can do an in-plane approach wherein you're parallel to the probe, or out-of-plane approach wherein you're perpendicular to the probe. If you look at this ice ball, it's pretty big and very well visualized on a needle tip. The needle tip will look like this if there's an ice ball when you're doing an out-of-plane approach. Diagnostic nerve block. As the first step, well, I think it's the second step. First step is to evaluate the patient, which you always do. The next step would be doing a diagnostic nerve block. What does a diagnostic nerve block entail? What are the tools required for this? A diagnostic nerve block, you would need an ultrasound, to be precise. This is a nerve stimulator which is commonly used by anesthesiologists. I've talked to a lot of physiatrists, and they don't seem to be using this. Obviously, this would be a new tool for you to get used to. The other thing is needles. We're very good at using needles. There are different kinds of needles. This is one of the nerve stimulator needles. There are many companies out there which will provide you different nerve stimulator needles which you can use. There's a port for the injection of local anesthetic and a port for the stimulation connection. when it comes to cryoneurolysis supplies, obviously you will need the cryo machine that you'll be using, an 18 gauge or a 16 gauge or a 14 gauge catheter, which allows you to introduce through the skin, because a lot of the times the tips are blunt. That's one reason. The other reason is to make sure you don't cause a frostbite to the skin that you're working around. This is the iOvera system. We'll talk about that as well. How does an ice ball form on the tip of the needle? Well, it's called the Joule-Thomson effect, wherein a gas flowing from a high pressure to a low pressure chamber causes a steep fall in temperature, resulting in an ice ball formation. There are different systems in the United States that are FDA cleared, FDA approved for cryoneurolysis. You're looking at EpiMed. This is the machine, how it looks like. It can be connected to a nitrous oxide or carbon dioxide e-cylinder or a larger cylinder, or even if you're in a hospital system to the wall system where you can have nitrous oxide or carbon dioxide. The maximum temperature that this needle goes down is to minus 70 degrees Celsius. The temperature that we obtain is very important to make a note of. This is argon-based cryoneurolysis device by Boston Scientific. A lot of times I do see them at the interventional radiologists where they would do ablation of the renal tumors, liver tumors, etc. This is a different kind of machine from Articure, wherein they would do the cryo when there's an open procedure. For example, somebody has a thoracotomy, the surgeon would do an intercostal cryoneurolysis. There's an amputation, they would do a sciatic or a femoral cryoneurolysis before closing the wound. This is the only handheld device that you have. There is a nitrous cartridge. It's only nitrous. There's no carbon dioxide. And you have a handheld piece, which is docked on a charging dock. There's two needles. This is rarely used for spasticity. This is used for pain with a smaller needle like occipitals and genicular nerves. This is what we'll be talking about today, a longer needle, which is about 90 millimeters. Now, each cycle is about 105 seconds. So the screen will show how many minutes or how many seconds are left. 60 seconds is the freeze. There's a thaw of 45 seconds. You can look at the size of the ice ball at the tip of the needle here, which is about 1.5 centimeters or 50 millimeters and 7.5 millimeter in width. So I was talking about the open probe that you could use. So this is an example of how intra-procedure cryoneurolysis can be performed using the Articure. So this patient had a dysarticulation. They did a brachial plexus cryoneurolysis, and the patient had no acute or chronic pain at 6 months. This was very powerful when it was reported. So it's like the power of cryo is there, and it will be lasting. The iOvera, which is the handheld system, has been approved by the FDA for cryoneurolysis of sensory nerves only. So any application is considered off-label. Let's go over the anatomy of nerves. This is, we'll be talking about cryoneurolysis and how safe it is. As you know, the nerve has epineurium, perineurium, and endoneurium, and the axons here. When you do cryoneurolysis, there is a second-degree nerve damage, which is fully reversible in the sense there's loss of axon, but the endo, peri, and epineurium are intact. So iOvera is at minus 88. The EpiMed device goes to minus 70 degrees Celsius. If you compare it to thermal ablation, still, cryoablation is where tumors are ablated. That's at minus 140 degrees Celsius. iOvera is safe within the minus 100 degrees Celsius, so is the EpiMed device. Now, what are the contraindications? Obviously, patient refusal. Raynaud's syndrome. If a patient has a Raynaud's syndrome, you want to avoid that. Cryoglobulinemia, cold urticaria. You see an image of this patient who had a cryoneurolysis and a week later developed cold urticaria. Any bleeding disorders, localized infection where you cannot place your needle, pretty bad anticoagulation. I mean, you can do use your clinical judgment when it comes to anticoagulation. Anatomic inaccessibility is a big thing when it comes to spasticity, as a lot of times you're unable to open the areas to access. You might need general anesthesia in these cases, so plan accordingly. When it comes to safety, this is the microscopic structure of a nerve with all axons in the green and the coverings around. They were all intact. In about 8 weeks, almost everything kind of starts regenerating, as you can see. A similar thing, a demonstration of an electron microscopic structure. What happens to the structures around the muscle or the nerve that you're targeting? It tends to spare most of it. As you can see, at 8 to 32 weeks, blood vessels, fat tissue, and surrounding muscles appear normal on histology after cryoneurolysis. So a transient injury obviously is resultant from the cryoneurolysis, but most of them do recover at 2 to 3 weeks. So what is spasticity? Again, I think most of the audience here are physiatrists. You work with spasticity a lot of times. In layman terms, it's abnormal muscle tightness due to prolonged muscle contraction. It's just tightness or stiffness that the patients would complain. As we know, the pathophysiology here is lack of upper motor neuron inhibition, lack of antagonistic muscle coordination, and there's a neurotransmitter imbalance. Spasticity, as you know, may result in loss of function, which is very evident, and pain at times. Now, what are the causes of spasticity? In this area where we see stroke, cerebral palsy, spinal cord injury, TBI, multiple sclerosis, genetic etiologies, the one thing that's missing is, as I mentioned, patients who have had surgery and have chronic pain after tend to develop spasticity as well. Now, pain is more prevalent in cerebral palsy, spinal cord injury, TBI, than stroke when it comes to spasticity. Something to know. So what are the current treatments? As you already know, there's oral agents pretty commonly used like baclofen, alpha-2 agonists, anticonvulsants, interventional treatments like intrathecal baclofen. Again, intrathecal baclofen is a big procedure for the patients. Then the maintenance, the side effects, the complications. Botulinum toxin is probably the #1 used treatment now for spasticity as we speak. Phenol is also used in some of the facilities. Physical manipulation like surgery and bracing are obviously options. Other peripheral acting agents like dantrolene sodium have also been used. When it comes to cryoneurolysis, as I mentioned, there are 2 steps. Step 1 is diagnostic nerve block. Why do I need to do a diagnostic nerve block? Well, just to have a mapping, you need to map your nerves, your intramuscular branches to the muscles you're targeting. Also, prepare yourselves as to how it's going to be when it comes to cryoneurolysis after the nerve block's done. For the patient, it gives them, okay, is my spasticity better? Do I have less pain after this procedure? Are there any dysesthesias, paresthesias? Can I live with these side effects, if any, after the nerve block? A lot of the times, local anesthetic choice is lidocaine or ropivacaine. I usually use ropivacaine 0.5%. The volume injected is usually 1 to 2 cc at the max. We don't inject a lot. Sometimes I only inject half a cc of the local anesthetic for diagnostic purposes. Using a peripheral nerve stimulator. Again, there's many companies out there which you can buy a peripheral nerve stimulator. So the iOvera system has nerve stimulation in the needle, so does the EpiMed system. You use up to 1 milliampere of current to elicit a motor twitch inside the muscle. I'm putting this again saying, okay, these are the things we need. We just need a needle, a nerve stimulator, and ultrasound, and obviously the local anesthetic of choice that you would choose. What are the targets? There's many targets. We'll be talking about all these targets today as much as we can with the time allowed. When it comes to upper extremity, suprascapular nerve is a good target for post-stroke shoulder syndrome. Something you can certainly target. The ultrasound image would be this way. Patient could be sitting if they're able to. If not, they could be prone. You're looking at trapezius, supraspinatus, and suprascapular notch. Here's a video of how to find the notch. You're above the spine of the scapula. You're scanning a little more medial, and you would find the suprascapular notch, suprascapular artery pulsating. Let's play a suprascapular nerve block being done out of plane. So in this case, the patient's sitting comfortably, being monitored. If they're not willing to, always have them lay down. So here's the medicine spreading. That's how you would do an out-of-plane. As I mentioned, you can do any plane or out-of-plane approach, just what you're comfortable with. Let's look at in-plane and out-of-plane approaches for suprascapular nerve blocks. I'm just putting them as a comparison here. At the end of the day, I choose whether to do out-of-plane or in-plane depending on the patient's body habitus, whether it's right side or left side, how difficult the anatomy is. This is an in-plane approach. You can see the needle. Here's an out-of-plane approach wherein you just see a tissue displacement coming to open up the space here. This one's already open to open up. This one's opening up here on the right side. So here's a depiction of how you would actually do the cryoneurolysis as well. Same thing applies. It's a deeper nerve, so you can always do an out-of-plane approach and in-plane. As I mentioned, you would want to use a catheter for easier insertion of the probe because the probes are blunt, and also to prevent any freeze injury to the skin and subcutaneous tissue. Pectoral nerves are an important target. As you know, lateral pectoral nerve, which is found between the pec major and pec minor, innervates the pec major muscle. Medial pectoral nerve is found between pec minor and the serratus anterior, and a lot of the times it's actually found in the pec minor itself. It's responsible for innervation of the pec major and minor. As you know, these nerves are actually brachial plexus nerves. They are not thoracic nerves, though we work in the thoracic area. Lateral pectoral nerve comes from the lateral part of the brachial plexus. And as you know, it innervates the pectoralis major, which has flexion, adduction, and medial rotation beyond. Here's a video of the lateral pectoral nerve patients, supine. They are propped up to about 45 degrees. I will show you a better videos soon. I'm under the clavicle with my probe, which is a high-frequency probe. Here we're not using a nerve stimulator because a lot of the times the nerve is visible. Again, if I can see the nerve really well, I don't need a nerve stimulator. If I can't see the nerve, or the nerve is very small, especially when we're doing intramuscular branches, we will need a nerve stimulator. Here's the same video, I think more magnified, so you can see the pectoralis major and minor. I could see the pectoral vessel and the nerve here. So we're just going to go ahead and bathe the nerve. The nerve's actually flowing in the fluid now. When it comes to cryoneurolysis, this was a patient who's really skinny. As you can see, pleura, this is the subcutaneous tissue. Pec major is really thin. Pec minor, as you can see, is all, there's scar, there is calcifications. You see the tip of the needle. I'm so close to the pleura, so you have to be careful when we're doing these procedures, how close you can be to critical structures. Here's the ice ball forming in front of the tip of the another lateral pectoral nerve cryoneurolysis. A major and minor. We've already injected the local anesthetic prior to the cryoneurolysis. You start seeing a small ice ball form here at the tip of the needle. As you see, the ice ball is anechoic. You see a hyperechoic needle here, hyperechoic pleura. Medial pectoral nerve, as you know, it originates from the medial parts of brachial plexus. It innervates the pectoralis major and minor. Here's how we find the intramuscular branches of the pectoral, intermuscular branches of the medial pectoral nerve. This individual was, very well built. So we're in the major, minor. I'm trying to see if this hyperechoic structure could be the nerve. So this is a stimulating needle. So we're going to keep fishing around until we find a motor twitch, as you would see pretty quickly here. I'm trying to see if there's any here, nothing there. So we're going to redirect the needle at this point and see, do I have to go a little more medial or lateral? We see pleura at the bottom. We see rib here. Now you see the twitch. So that's why your nerve stimulator is a very important tool in identifying these targets. So is the ultrasound. So when we found the twitch, we would just go ahead and inject a little cc or two of the local anesthetic. Now, if you see the twitch immediately disappears, we would think that, hey, this is probably the numbing medicine numbing the nerve, but it's actually not the case. It's something called a Rod's phenomenon, where the local anesthetic pushes the nerve away from the tip of the needle, which stops the stimulation. Here's some videos from Paul Winston, who did the cryoneurolysis medial and lateral pectoral nerves, brachialis, PT, and FCR. Pretty impressive before and after videos.
Here we go. Whoa! Oh my God! That's crazy. Oh my God! Holy hell! Oh my God! Oh my holy cow!
It's pretty impressive. Now, thoracodorsal nerve is an uncommon target, but I wanted to bring this to your attention. Thoracodorsal and long thoracic, both are again from brachial plexus. Thoracodorsal nerve supplies the latissimus dorsi, the outermost muscle. So you would see the latissimus dorsi, you would see the serratus anterior, and then the nerve is interspersed between. And this neurovascular bundle could include the long thoracic as well. Patient positioning would be lateral decubitus. So in order to find that, you would want to use a nerve stimulator. This is just a thoracodorsal nerve block without a nerve stimulator, but I'm just showing you how that might look like when you're actually using a nerve stimulator. You would see a twitch of the latissimus dorsi when we're close to the thoracodorsal, and you will see a twitch of the serratus anterior if you're close to the long thoracic. So it's very important to distinguish when your needle is in this interfascial plane, which nerve you're targeting and what muscle you need to stimulate before you inject the local anesthetic. So here's the long thoracic. As you can see, it supplies the serratus anterior. Here's a long thoracic nerve cryoneurolysis in a patient we recently did using the EpiMed system. You see the EpiMed system here. This is the needle. This is a sharper tip, so we didn't actually have to use the 16 gauge angiocatheter. So here's the ribs and pleura. Needles, we already anesthetized the nerve before. You can see the needle in the interfascial plane, more close to the serratus anterior. So you start seeing the small ice ball forming, which is anechoic. Here's the ice ball this time. So the cycles usually last about 2 minutes for each nerve. Again, very skinny patient, very close to the pleura, so it becomes challenging for us to keep the probe away from pleura. Now, musculocutaneous nerve is an important nerve, as you know. There's branches to the biceps and the brachialis. Important functions are, supination of the forearm, elbow flexion. So if you want to do a musculocutaneous nerve block or cryoneurolysis, you might want to consider the function of the patient. Does the patient have a very good supination, or just treating the elbow flexion? Then you might want to not treat the biceps and then just go ahead with the brachialis only. So as you can see, targeting the trunk may cause some sensory loss down to the hand, since the trunk is a mixed nerve. So it is a mixed nerve, it's not a pure motor nerve, so you have to be careful about dissociations after the cryoneurolysis. Here's the musculocutaneous nerve between the biceps and the coracobrachialis. Here's the nerve block of the musculocutaneous nerve. When you see nerves like this, you really don't need to have a stimulator if your target is just to get the musculocutaneous. Here's the axillary artery. We're just putting about 2 to 3 cc of local anesthetic that surrounds the musculocutaneous nerve. Here's brachialis and biceps. So if you want to preserve the sense, the supination, or just say, I don't want to be dissocious, then you might want to consider blocking the intramuscular branches of the musculocutaneous to brachialis and the biceps. As you can see, this is the bifurcation. Let's take a look at the scanning part of it when you're using ultrasound. So here's the musculocutaneous nerve, axillary artery. I'm just going now distal, humerus. Here's the nerve. It starts dividing and producing branches into the then you have the brachialis branches here. We're going to put the biceps and brachialis. So I'm going to scan back up. You'll see those two branches coming together into a single unit of the musculocutaneous right here. So we can do the musculocutaneous, or we can capture the branches that are coming out from the musculocutaneous nerve, targeting the specific muscles we need to target. So musculocutaneous cryoneurolysis would look like this. Obviously, we are treating the trunk in this case. We did a diagnostic. Patient did not complain of any major dysesthesias. They were happy with the outcome, and then so we're getting a small little twitch here because the amperage of the nerve stimulator was very, very subtle, and also we put in a little local anesthetic prior, so for more comfort. Radial nerve. When would you do radial nerve? I mean, you wouldn't want to really cryo radial nerve. It's a major nerve to your forearm and fingers and stuff. So just, I would say we would cryo the intramuscular branches that radial nerve gives off. So here's the radial nerve sonor anatomy in and around the radial groove. Your approach could be patient sitting down or laying lateral decubitus. Brachioradialis is an important muscle which you can target if we have elbow flexion, supination, and pronation issues in patients. As you know, the distal portion of the radial nerve lies between brachioradialis and brachialis. We're going to target and find and target that radial nerve and its branches to the brachioradialis. Here's the radial nerve to brachioradialis. There. It's still the radial nerve. It's starting to branch now. So it would start stinging somewhere here, see if that would sting the brachialis, and then choose to do a nerve block or cryoneurolysis as needed. There's the nerve, muscles that most likely the branch is branching out here. There's so much anatomical variability, so that's why you need to have a nerve stimulator to be very precise as to where exactly the branch is and how big the stem and what stem you're getting. This is a radial nerve block at the level of the radial groove of the humerus. So again, if a nerve is so big, we don't need to actually stimulate nerves like these. So because they're so big, it's just not necessary to use a nerve stimulator and cause undue discomfort for the patients. Median nerve, I think it's a great target, especially patients with flexed wrist and clenched fist. Again, there's two levels where you can block it, either above the elbow or a median nerve below the elbow, depending on what you're trying to attain. So this is about at or about the elbow with the brachial artery. Here's median nerve in the forearm, very well visualized, right smack in the middle. You have flexor digitorum, superficialis, digitorum profundus, pollicis longus. This is a depiction of median nerve under ultra high frequency probe, when you can really see the characteristics of median nerve. It's a diamond-shaped nerve, very hard to miss when you scan the forearm. So median nerve, we're going to start scanning here. Here's the nerve. As we more distal or mid forearm, I'm going to scan just We keep scanning to the front, close to the wrist now. Becoming close and superficial. Here's the median nerve, I'm just tracking it. So we went from the elbow down to the forearm, now we're going slightly up. This is the middle of the forearm again. So easy to find nerve. You don't need to use nerve stimulator if you are targeting the entire median nerve. You do need nerve stimulator if you're targeting the other muscles, as we just talked about, just surrounding the median nerve. So this is a depiction of a median nerve block in the forearm. We're doing an in-plane approach where you can see the entire needle come through. You want to see the medicine spread uniformly around the nerve as much as possible. Here's the median nerve cryoneurolysis. Again, we did a diagnostic. She didn't have any dysesthesias. She was happy. She had a clenched fist. As you can see, this is the ice ball. Again, very difficult positioning. You know, I'm standing right behind the patient, probes on the forearm. The ultrasound probe and the cryo probe is coming from the other side. Ulnar nerve, when you do one, I mean, same thing like median, you would do above or below, depending on how much of a flexion deformity the patient has. I prefer doing that below the elbow, so I don't have to affect most of the muscles higher up. So you can go a little more proximal to the ulnar groove and then find that between the brachialis and triceps muscle, or you can go below and be close to the ulnar artery and vein. So here's a sonoanatomy with ulnar artery. You have flexor digitorum profundus, pronator quadratus. Here's an outer plane approach to doing an ulnar nerve block. Again, as I mentioned, it's just your comfort as to how you want to see. You can see the tissue displacement of the needle. We're getting close to it. I'm just using a 27 gauge needle at this point to do a diagnostic nerve block in this patient. We see the spread of the local anesthetic around the nerve, so that's a good sign. Here's an in-plane approach to ulnar nerve block. So we're just going radial ulnar side. We're starting from lateral to medial in this case. We want to see good look. So here's the needle tip, entire needle, and we are seeing the medicine spread around the ulnar nerve. Ulnar artery is still pulsing there. Cryoneurolysis, same thing. We have ulnar artery. Here's the ulnar nerve. We usually anesthetize right prior. Again, I don't need a nerve stimulator at this point because I can visualize the nerve really well. And you want to see a nice ice wall form right on top of the ulnar nerve. So you see the anechoic shadow coming up, completely engulfing the nerve pretty much at this point. So we're very shallow, about a centimeter under the skin. Becomes a challenge, especially when it comes to kids and smaller individuals, when you don't have much real estate to work around. When it comes to lower extremity, the first nerve I would like to talk is obturator nerve. As you all know, there's an anterior and posterior division. The anterior division supplies the adductor longus, brevis, and gracilis. The posterior division tends to the adductor magnus and the obturator externus. So if you're doing a block, you want to probably do both, because a lot of the times both nerves, almost all the adductors are involved. So you want to get the anterior and posterior divisions at the same time. Most of the patients, as you know, would probably present with scissor gait or adducted thighs. Patients, it's hard if you have real bad spasticity to open up the thigh like this one, but you might need many people helping you out in separating the legs, or use anesthesia to help you out. So here's how your fascial planes will have the anterior and posterior divisions. I'm going to show you a nerve block. This is the femoral artery. So we have the longus, brevis, and magnus. I'm going to use a nerve stimulator just to be sure I get the anterior division. Here's the anterior division. We have a nice stimulation. We'll inject a CCO2 and then keep proceeding further down to get to the posterior division. So we're looking, it's injected, and then we're looking for the second twitch. Here's the second twitch of the posterior division. We're going to inject there as well. So that will be your the operative nerve block, getting the anterior and posterior divisions. Femoral nerve. Now, if somebody comes in with quad spasticity, or then you might want to look into different nerve branches that the femoral nerve gives to different anterior thigh muscles. As you know, the posterior anterior division, the anterior division gives the nerve to the pectineus and sartorius. The posterior division gives to vastus medialis, lateralis, intermedius, and nerve to rectus femoris. This seems to be the more important nerve to target in spasticity. Here's the cryoneurolysis of the iliacus, the intramuscular branch of the femoral nerve to the iliacus. As you can see, the femoral artery is here, femoral nerve is there. There's an immediate branch which I'm able to stimulate, and then we just go ahead and cryoneurolyze that small intramuscular branch. Patient had severe hip flexor spasticity, which wherein we decided to do this intramuscular branch of the femoral nerve to the iliacus. So when it comes to rectus femoris, the branch which is most commonly targeted, as you can see, this is the rectus femoris in the front. It's responsible for hip flexion and last few degrees of the knee extension during the swing phase. Patient can present with painful or stiff knee gait or painful spasms. Here's the femoral nerve artery, ice ball depiction. Let's see how to find one of those. So you will see the femoral artery dividing the anterior and posterior divisions. Then you'll see the sartorius muscle up here. Then lateral to it is your rectus femoris. As you can see, these white structures going along, these are the branches coming out to the rectus femoris. So you might want to stimulate one of these to see if the rectus femoris gets a nice motor stimulation. Then you're sure it is, and you still might have more branches within the bulk of the muscle, like these hyperechoic or white lines. So you might want to move your needle closer to it and see if there is a stim that you need to target as well. So here's the whole rectus femoris here. We're tracing it back into the femoral nerve, I believe, at this point. As we go back, here's the sartorius again. So find the sartorius and just start scanning a little more lateral to it to find these. Here's a patient with issues with his knee with spasticity rectus femoris. So we're doing a rectus femoris intramuscular branch of the femoral cryoneurolysis. This is a video of a patient with a very spastic iliotibial fascia, tensor fascia lata. You can see his tensor fascia whole muscle just twitching as we're doing this stimulation before the cryoneurolysis. Sciatic nerve is an important target. Again, sciatic nerve, where would we target? We can target subgluteal and also in the popliteal crease. So here's an image of the subgluteal approach with multiple branches to the that are going out into the hamstrings, as you can see. You have biceps femoris, semimembranosus, and semitendinosus. Your hamstrings. This was the anatomic depiction of multiple branches that are coming out from the sciatic nerve to different muscles in the hamstrings. This study was surprising. They said no branches originated from the sciatic nerve below the lower edge of the gluteus maximus. But whenever I've seen many branches that are either branches of those larger branches in the hamstrings that we were able to target. And also, if you can see, there's the average number of sciatic nerve branches for the hamstring muscle was 4.7. There's a lot of branches that you need to target when it comes to hamstrings in the sciatic nerve. Another image, video actually, sciatic nerve branches. So here's the full sciatic nerve, femur. They start becoming thinner and thinner as they start branching out. So you might want to just trace these things and then start stimulating and see if you get the stimulation of the particular muscle you're looking into targeting. Tibial nerve, I think very important and probably the most common targeted nerve for spasticity is tibial nerve in my practice. As you know, it has branches to the gastrocnemius, soleus tibialis posterius, and flexor digitorum longus. It is a mixed nerve, therefore treatment may cause heightened dysesthesia. So a diagnostic nerve block is very important to see if the patient has dysesthesia or not. And if they're okay with it, and if they have equinovarus deformity, then you can go ahead and get the entire tibial nerve trunk. Here's the tibialis posterior muscle, flexor digital longus, going on to all the toes except the big toe. Tibial nerve trunk. So when would you do what muscle or what intramuscular branch of the tibial nerve? Somebody comes with clonus or spasticity with foot in dorsiflexion and knee in extension, then you might want to consider gastrocnemius. They also have clonus and spasticity foot in dorsiflexion, then soleus should be included as well. If somebody has an isolated clawto appearance, then flexor digital longus is the only thing you might want to consider. Or if they have isolated foot inversion, then tibialis posterior is the only thing you need. If patients come with equinovarus, then you can get the entire trunk. So here's an equinovarus deformity. We're doing a tibial trunk, patient's lateral decubitus. Here we're in the popliteal crease, so popliteal fossa. Here's the gastroc ice ball in the gastroc, patient's prone. I would like to play a video. Here's a needle. We're looking for a nice gastroc intermuscular branch twitch before we freeze, so you see a nice twitch. And then at the end, you would start seeing the ice ball form. So everything's real time, as you can see. It's very interesting to see these live and see the effects immediately after. Here's the ice ball, which is the anechoic shadow that's forming in the gastroc. So if you really want to see the effect of cryoneurolysis, this is a great video we recorded the other day. Patient comes in with clonus, literally like, okay, let me just do this video before and see what happens to the clonus after. So we do the cryoneurolysis of all the muscles we target, and then hear me literally pushing my entire body weight onto his leg, and there is no clonus. So we try again. I said, I'm going to put more pressure, put my entire body weight, and the clonus disappears immediately after. So the effects of cryo seem to be very, very impressive. As I mentioned, post-surgical pain and spasticity are not uncommon in my practice, and that's how I treat both post-surgical pain, spasticity, and also spasticity from other neurological conditions. Here's a patient with CRPS for 16 years. That was her foot, and this is her foot immediately after the diagnostic blocks. We actually finished cryoneurolysis on her a few weeks ago. You can also target the posterior tibial nerve at the ankle for intrinsic muscles of the foot. It's rare to see this, but if you do see, you can target the nerve more in the medial aspect, just at or above the ankle level. Here's the medial malleolus, Achilles tendon, posterior tibial nerve. Here's an outer plane approach to tibial nerve at just above the ankle. So here's the posterior tibial nerve, posterior tibial artery, Achilles tendon, tibial medial malleolus. So in an outer plane approach, you can see the tip if your angulation of the beam is accurate. So here's the needle. I'm just playing with it and just pushing it down so that the nerve gets bathed in local anesthetic. So in this case, I don't need a nerve stimulator. I can see the nerve, so I can just do without a nerve stimulator needle. So here's one of the difficult cases that calls took care of. I think this is the adductor spasms, spasticity they come in with, and it's very difficult to open these legs up.
Tilted to the right side. And in fact, he cannot lie straight on the bed because of the tightness in his hamstrings pulling and the pulling together of his legs. And the knees will not extend to 90 degrees. You can see the buttocks are raised off the bed. We are going to target him for cryoneurolysis of the lower extremities. By inserting a percutaneous probe through the skin and generating an ice ball, we will target 2 sets of nerves for the patient. Here we see what the ice ball looks in some saline. It generates from the water inside a patient's muscle and no drugs are injected. This is the percutaneous approach that we use with ultrasound guidance. Here is a demonstration of cryoneurolysis of the obturator nerve. We do two branches, the anterior and posterior of each nerve, to make sure that we target as many muscles as possible, as the legs pulling together is the greatest problem. After the procedure to the bilateral obturators and sciatic nerves, we can see that the legs the next day are open more apart, and he's already beginning to We are demonstrating a patient that has had botulinum toxin and phenol injection.
So billing is an important part as well. So I thought I'll quickly go over these. You can use the 76940 for your ultrasound guidance. Some of the nerves, you cannot use ultrasound separately because there are bundled payments for brachial, sciatic, and femoral nerves. If there's a separate nerve that you're doing, like an intramuscular branch, you can use the 64450. In a hospital setting or HOPD or an ASC setting, you can use this as Medicare does cover them. Under those, in an outpatient setting like mine, Medicare does not cover, so most of my patients pay out of pocket. More codes, but these are applicable to cryoablation, so I don't think we could be using it, but there might be a workaround which you can discuss with your hospital systems or places you work with. The reimbursements are mostly, as I said, these are for the cryoablation, so I'm not sure we can use it for cryoneurolysis because the cryoablation procedures are done for tumors and their temperatures are minus 140 degrees Celsius, not 80 or 70 degrees Celsius. Summary, clinical discussion to be used in targeting nerves for treatment with cryo. If you're an anesthesiologist, you might want to, collaborate really well and closely with your physiatrist. If you're a physiatrist and you would like to learn something new, like using a nerve stimulator or nerves, finding nerves, or using ultrasound, you might want to invest some time into learning those as well. Diagnostic block is almost a must for these cryoneurolysis. Start with most proximal muscles and progress distally. Adjust treatment as necessary. Just a reminder again, this is a QR code which you can scan. We have 3 workshops. Again, you would say, well, I just listened to this whole thing. Why do I need a workshop? Well, the benefit of a workshop is now you'll have hands-on scanning for about 4 to 5 hours. We also include the pain part. We'll be targeting occipital nerves down to the sural nerves. So you will have a lot of pain targets, which you can also address these patients might have. So you're getting better in diagnosing and treating pain and spasticity together. So you will have a very good, experience in scanning multiple live models and learning real time. This is a QR code which you can, again, you have 3 workshop dates for this year. We're also the only workshop in the United States that actually offers a full day workshop. Last but not the least, we do have the 2nd annual scientific meeting on post-surgical pain due December 5th and 6th in Tampa, Florida. So we would love to see you if you're interested in post-surgical pain. So this will be recorded and be available in the next few days, the whole presentation. Nick's going to help me out with that. If you have any questions, I'm happy to answer. Please put them in the message board so I'll be able to answer the best of my abilities. I don't see any messages in the chat or Q&A. We'll give it a few minutes if somebody has any questions that I can answer. If not, we'll call it a day, and the video should be available as a recording very soon. Question was, could you go over again your technique for CRPS of a sural nerve, for example? This is a question by Dr. Farid. Again, Dr. Farid, we are dealing with spasticity. This is a question for pain, but I'm going to answer that anyway. Basically, we have to do a diagnostic nerve block of the sural nerve. I usually get the sural nerve at around the calf in the posterior aspect, where it lies right about the gastrocnemius. Once we have a diagnostic block, which is at least giving 50% or more relief, then we'll go ahead with the cryoneurolysis. And there is Dr. Katab who says, thank you. Duration of effect, complication of the procedure. Duration of effect, again, the nerves regenerate in about 90 days. So we expect anywhere from 90 days to 6 months to a year or two. Again, as Paul and other colleagues throughout the world are compiling information, we will know more how long it would last. Complications of the procedure, as I mentioned, like any needles, you can have infection, cold urticaria. Pretty safe though. Overall, it's a very safe procedure. Cryoneurolysis could be used in children. Absolutely, yes. There is a couple of children's hospitals within the United States, in Atlanta and Philadelphia, that actually do these procedures under anesthesia. What is the gap between diagnostic and cryo? So it depends on the local anesthetic that you use. Let's say you do a long-acting local anesthetic, or you want to give the patient more time. It's probably not beneficial to do it the same day. Let's say a patient comes in 8 hours traveling to you, then you might want to do a 0.5% lidocaine or 1% lidocaine in the morning. And maybe in the evening, you can get them in for cryo, because if you put the lidocaine, then you cannot stimulate the intramuscular branch. So for those reasons, the gap I usually use is about a day or two. Let them go home, do what they usually do, get a better sense of how much of a relief they get, and then come back for a cryoneurolysis on a separate day. Thank you, Dr. Siddiqui, for your question. All right, Nick, looks like we have all the questions answered.
Yeah. Like you said, we'll have this available in the next few days, and then we'll let everybody know about the next webinar in our 2026 series.
All right. Good night, everybody. Thank you, Nick.
Take care.